Welcome to the Beyond Pain podcast with your host, Joe Gambino and Joe LaVacca. Join the two Joes, two physical therapists, as they discuss how to navigate the uncertainties of pain so you can move beyond it and get back to the activities you love most. This podcast is for Joe, and their guests to share their clinical thoughts and ideas based on their collective clinical experiences. Can this information be for you? Maybe, but we cannot know for sure. Therefore, it is always worth talking to your healthcare provider to make the best decisions in your care before you implement anything on this podcast. And please use common sense.
Welcome back to the Beyond Pain podcast. I am one of your hosts, Joe Gambino, and I am here with our other host, Joe LaVacca. You can find us on social media at Joe Gambino DPT for myself and at Strength and Motion _PT for LaVacca over here. I will skip everything else because we do have a special guest with us here today. We have Steph Allen. She's a physical therapist, the founder of ACL Resolve, and the co-founder of Clinical Athlete. Welcome in.
Thank you, guys. Pumped to be here.
Yeah, as well. Why don't you take a quick step onto the stage here and tell our listeners a little bit more about you.
Yeah. So, and we were just talking a little bit about this, but I have been a PT for 11 years now. Pretty crazy to think. Actually had to do some math in my head there for a second.
Yeah, when you have to think about it for a second, you know it's been a while.
North of 10 starts getting a little scary. You're like, wait, really? That makes me an expert, I guess.
You're allowed to say decade now? That's weird. But yeah, I've been a PT for about that time. I would say, like, obviously now, so many people associate me with ACL related stuff, which is great. That was like, originally, well, not really originally the plan, but ironically, I didn't dive super deep into ACL specialty probably until doing travel PT a couple years out of school, I would say. And then kind of never looked back, but was doing travel PT and recognized it didn't seem to matter where I went, different states, that this particular injury, lack of better terms, wasn't really well cared for, especially in the insurance model. And I wanted something different. So I landed at kind of a forward-thinking, privately owned sports clinic in Boston in 2017. And that's really where I kind of like honed, anything I read, any continuing ed I did, most of my patient caseload became, by the time I was done in the clinic, probably 90 to 95% some sort of knee injury, not necessarily ACL, which was a lot for working full time, but I learned a ton in that time, and it kind of like afforded me the confidence and mental place to be to actually start something like ACL Resolve, which is what I thought would kind of allow me to give the patients and clients what I didn't feel like I could fully give in the clinic.
Was there something specific about the ACL rehab frustration or anything else? Because I'm sure you saw lots of interesting things in your travel, but what stuck out to you about that ACL that you were like, hey, I need to dive into this because people need help here?
Yeah, it seems to be that people would get to and by people, I should maybe clarify that more, like the most glaring examples of it to me were the adolescents between, early and mid 20s, maybe even late 20s, super active people who were basically like insurance was cutting them off after like 3 or 4 months, which again, like there's even more research now, but even at that time, again, 10-ish years ago, it was still thought that like it might be realistic between 6 and 9 months, which again, debatable now, but based on what we have. But either way, even knowing that, it didn't match up to me. I was like, if research is telling us this, and like clearly this person at 6 months, especially depending on what they had early phase in terms of care, is not ready, then what's the, so again, I looked at that, what I was seeing in the clinic, and most of these in travel PT was hospital-based outpatient, where pretty high volume. The clinics themselves were almost never really well equipped in terms of bringing people, and by that I mean space, weight, testing, pretty much never really was a thing there. So that was another little hurdle. But, seeing this in the clinic and then also realizing that, I'm learning the different insurances and how they work. And I'm like, something like it just doesn't make sense. There's nobody ready at 6 months. You know what I mean? So there was that. And then I think just also seeing some of the nonchalance, maybe like, I don't know if that's a word, nonchalance, but like,
We'll take it.
yeah,
We're very
like,
we're very lax here on the podcast, Steph. You can make up words whenever you feel like it.
yeah, but even like other colleagues in places like that where, the early phases, which again, I'm sure we'll talk about this, simple but not easy. Again, sort of like going through the motions, everybody did the same exact thing, even if they were having trouble with, quad activation or things. Again, at that time, I wasn't even really well versed on, but I knew something was up. So there was just a lot of things that didn't fit. And I was like, I feel like there's got to be a better way here. And so then I just started digging and like finding mentors and stuff.
So I was going to ask, you just mentioned when you started, you were like, oh, I'm not too sure. I'm seeing these things with ACL, but, I knew something was up. I'm not like 100%. And you went and you did the research and, now that you're an expert in that area, how would you look at that as like, or what would you say is the benefit of looking for someone like yourself who spent some time doing all the research and kind of specializing here versus going to your traditional PT up the block? When, or even really when should someone decide between the two?
And are you talking about like for care or like mentorship?
For care.
Gotcha. Yeah. It's so interesting because I know so many like really good PTs who know their stuff in the insurance-based system that depending on where they are, sometimes they literally are kind of handcuffed with what they can actually do. And so I would rather them be seeing those people than nobody if someone like me is not an option because currently I'm not through insurance, which I totally understand. We try to make things as kind of budgetable and affordable as possible, but it is one of those things that you have to ask yourself where if what you're trying to get back to is either like super high level organized sport all the way up to, we've worked with like semi pro or those types of situations where what you have available to you close to you is maybe not necessarily because I've talked to a lot of people who go to whoever takes their insurance and, they're maybe a little bit more on the active side or they're getting to a higher level. And it takes them maybe two visits to figure out like, I don't know if I'm gonna be really challenged here, and they don't necessarily know how to describe it, but I know exactly what they're saying, like, what they're talking about, and so if you are starting to feel those things, if you get to even that point, like, some people know ahead of time, they do research and they're like, "I'm not gonna go to the place near me, I know what it is, I went for my shoulder, and most of the people are 30 years older than me, I'm doing similar exercises to them." Again, these are kind of, like, quintessential things I hear, it's not always the case, but a lot of times it is, so some people know ahead of time, but other times I would say, like, if you're starting to get that feeling like you're leaving PT after the very early phases of maybe surgery or injury, and you're like feeling like you need to go work out or feeling like you need to do more, or, you've been doing the same things for several weeks without much change, especially in the early phase, I would, like to your point, look down the street or start to do a little bit of research.
I know you mentioned, Steph, too, that you're mostly or kind of all virtual right now with your ACL Resolve, right? Have you noticed any differences in outcomes? Because you were doing in person PT for so long and now going all virtual. I'm sure you've gotten, maybe some hesitation from folks like me and Joe do. Oh, I don't think I could do the virtual thing. I really need you to see me. So, have you noticed any differences? And if so, what are those differences? And how do you approach that when people are kind of pushing back on you? Like, I don't know if this virtual thing can really fit what I want.
Yeah, it's a conversation. Again, like, it's interesting too because there's so much information out there, and the longer you do it, you have like social proof of people who have done this before and things like that. I've even had former clients get in touch with a prospective client who's a little unsure. I've had clients in the past that were unsure and then did really well. So I'm like, great, talk to this person if you would like, but I can't make that decision for you. I totally understand. And there is a subset of the population that, like, honestly, I would say probably aren't the best for virtual. Like, I'm not saying it's for everybody. What I have noticed, though, to your point, is something I didn't expect to at first. The level of accountability that I'm able to have with people virtually is so different than in the clinic. Because what I was doing, just to kind of give people context, is they would maybe come see me twice a week if they were able to, if insurance, because again, with ACL stuff, we were usually trying to spread out their visits, right? So great. One option is to come once a week, once every other week, as you get later on, maybe it's once a month. But then I'm writing full ass programs for people between their sessions because I know that they're going to need to do
Right.
more than that, what they're doing with me in the clinic. And in that model, it's like, okay, that's fine. But there's no, like, I'm doing this on top of my notes and progress notes and all those kinds of things. You're not getting paid for it. So the burnout pretty quick if most of your caseload is that, which mine was. And the second of all, like, I don't know if they're actually doing it. Like I can venture to guess when we go to test, right? Like it's really hard. The majority of who I was seeing in clinic were either high school kids,
Yeah.
maybe some college kids who were home for summer. So like saw them for 2 or 3 months consistently. And then I would have to kind of like hope that they would continue stuff when they left, or busy working parents. And like all of the above is kind of a crapshoot in terms of like what they're doing in that time outside of in clinic time. And for an ACL injury, you need to be doing so much more than that. And so what I didn't, again, realize is like I was already kind of doing the virtual thing without really doing it. And then when people had the explicit, we had the expectations conversation in the beginning of working with me where like, this is kind of how it works in terms of frequency. If you're early post-op, you're going to have something in there every day, like to check off and to do. And part of it is like part of my job is if you miss a day or two or there's some issues and you don't communicate, I'm going to check in with you because, and now like people are paying for it too. So it's like a directly instead of like through their insurance. So I've found compliance to be incredibly improved. And then therefore, obviously the trickle down effects of those things are when we do testing every ideally 8 to 12 weeks, depending on what they have access to virtually, which I usually help them figure that out, then there is kind of steady progress every time we do that instead of, sometimes there would be people I would test in the clinic where I'm like, I don't know what they've been doing outside of here. I don't really know what this is going to go like. So yeah, I would have to look back. We track everybody's strength and psychological outcome data, and I have 3-4 years of that now. So I bet I could look at that and kind of, I should do that. Look at that and kind of see the trends, but it's been really like pleasantly surprising in that way.
I resonate with that sentiment because I feel like outcomes are just the same as when I'm in person as well. And I think having this kind of environment really allows you to spend more time with them, way more touch points, way more connection points. And Joe brought something up on another episode that we did a while back, which was interesting for me, and when you're virtually and you're doing this through the screen, you're not in a clinic, there's no music, there's a lot less distractions, and you're kind of just really just one-on-one, just you guys. And I think that was a pretty interesting point that I didn't think of before that's kind of unique to this environment. So I'll pat you on the back.
Well, thanks, man. I appreciate that. Well, I think, Steph, what I found surprising when I started doing more and more virtual stuff was it wasn't actually really an age thing for me. Now, granted, I wasn't as hyper focused into one area as like ACL recovery. So for me, I was always worried the older the patient is, the less technologically gifted they are going to be. And then I didn't find that to be the case. But there was one word that you brought up which really resonates. And I think it's the people who want accountability. And, that was a question I started asking was, what do you want out of this process? And people would be like, oh, to get stronger. Okay, well, you don't really need me to get stronger. I mean,
Yeah.
you could just go to the gym and keep showing up. What's deeper than that? And they're like, yeah, I'm just not going to do it if I don't have someone watching me. So that was great. And I realized that really the more people want to be checked in on and cared for, the better they do with us. One other thing you brought up is that I found it interesting, and I didn't realize this from the website or the stuff that I've been seeing, but like you keep track of the psychological variables throughout the recovery process. And Joe and I have talked about the identity of injury before. For kids, I probably realize this is much more acute because some of them probably have aspirations of college or maybe even, professional ball in some cases in different sports. So, big picture stuff when it comes to ACL, I think a lot of people maybe listening or going through it, you're pushing, hey, quad strength, quad symmetry, limb symmetry indexes in different, hop testing, I'm sure, and range of motion and swelling. But have you found any correlative data where if even people aren't hitting those goals exactly, this fear avoidance or kinesiophobia is maybe a bigger impact in their long-term recovery? Or is it really, really hit the biology stuff first?
Yeah, I would say like we do both, obviously, but there's no way around it. Like if people are, to your point, maybe they're like technically slightly behind, which is one of my like least favorite words in this
Mhm.
rehab, but there are certain indications where like, maybe they are not necessarily exactly where we'd expect them to be based on their graft that was used, if they had an injury before, how if we have this information, like how their swelling, range of motion, and quad activation was before surgery, like a lot of things go into that. So I do my best in terms of like that initial conversation with people of what they can expect, or if somebody seems very, when can I do this? When can I do that? Like very timeline focused, then I may be a little bit more explicit with this, but it is like the physical stuff we can't ignore. That is really the priority. And I'll tell people early on, like, these are your main jobs. It's like, get it as straight as possible, get your swelling
Yeah.
down. We get like they're, it's very hyper focused. But I will say, and I don't know if this fully answers your question, I will say there is a subset of the population where I kind of can get an idea just initially getting to know them and maybe their level of anxiety or lack of confidence, to your point, fear avoidance. Like when you talk to that person who injured themselves 2 or 3 weeks ago and they have done nothing because they are really fearful of anything hurting means that they're going to do something worse. And I know in situations like those that it probably is going to be a little bit of a slower climb. And so those are people that I'm probably paying even closer attention to. I use the ACL RSI, that it's a 12 question questionnaire that is validated for ACL rehab, but it asks more of those questions of how fearful are you? How confident are you in, how frustrated are you by, like, those questions open a lot of doors in terms of conversation. But the like TLDR is, yeah, in the beginning, there does have to be kind of a little bit of that push towards, we need these physical things done. And again, I'm not giving them ultimatums, but like, this is really what we want to focus on. If there's anything straying from that, or we're having a lot of trouble in a certain area, like in our medium virtually, like you need to let me know. And they also early on are sending me like, show them how to do like sweep tests and swelling things. And
Yeah.
lastly, I almost always would like them to have an in-person PT also in the beginning, even if it's just once a week for like those sorts of things, girth measurements, range of motion, manual therapy that I can't do, that honestly is probably helpful in the beginning, but not necessary. So yeah, I don't know if that actually fully answers your question.
No, I think it does, and maybe I can even do a better job at giving a different example. And I know my experience is not as extensive as yours, but typically when I was more inpatient or not sort of hyper focused on the persistent pain community as I am now, what my bias was, and I'd love your take on this, was yes, the biology stuff is really important, right? Like I do want you to get as straight as possible. I want you to get as strong as possible. So there's minimum expectations there. I'm not going to give you the go ahead if you're lacking, 5 degrees of extension and your quad strength is 50% of the other side. But there were so many different parameters. I think probably when we were all coming up out of school, it was like 80%, no swelling, right? Full range of motion, right? And I feel like those things maybe have been challenged a little bit more. But my bias was, and I told this to athletes, and again, maybe I was wrong, but I told them, I said, I'd rather you be, at 80% confident you're going to go back to your sport and do well, right? So no kinesiophobia, no fear avoidance, then be at 90% with the full range of motion and still be worried taking the field. And, for me, it always came down to the behavior then on the field. If I was a little bit weaker, but I was confident, well, maybe I just fall down and get up. But if I was strong and playing stiff and apprehensive, well, maybe I'm at a bigger risk for re-injury. Do you ever weigh anything like that? Should I stop telling people that sentiment? That's basically what I really need to know.
No, I don't. I mean, again, there's truth in that in terms of, I do tell people, if you are hesitant, if you're nervous, if you're not confident in any certain way, you're going to move differently. You're going to move cautiously, even if it's subconscious. And that's not something we want in the column of injury risk mitigation. Like we don't want that. I want you to move like fluidly, we want to essentially in somebody's ramp up to sport phase, if they're lucky enough to have it be with someone like me, or have that be overseen, because a lot of times it is just like, okay, you've passed these tests, you can gradually ramp up. So what does that mean? The coach doesn't know that, the kid doesn't know that, or individual, whatever. Even if it's like rec sports, when you're older, nobody ramps up to that. They work all during the week and then they go once one weeknight a week and they go ham. So yeah, it's that piece is huge. But what I would say too is that if you are being challenged the way that you're supposed to be, then there's very few people that are still lacking in confidence significantly, because they have been exposed to, on field, on court, whatever it is. They've been exposed to, you know, minute restrictions, and then, no contact, and then contact. And like, it's very calculative, if that makes sense, where, again, as it should be, like that's what a ramp up should be. In that case, you should be stepping on the field, to your point, like having already been exposed to stuff that you're sure that you can withstand. You should have already fallen and realized, oh, I can fall and I'm not going to retear my ACL.
Right. Right.
So it is tough. Like, I would say it's that annoying answer of it depends slash it's both.
Yeah.
Because, yeah, technically there's also pretty robust literature that if your quad is not strong enough, you're at pretty high risk. Even if it isn't for a reentry of the same injury, you're at risk for something else, because you'll compensate and some other tissues are going to take the brunt of it. And then you have a groin or hamstring strain. So, yeah, my answer
Well,
is
no,
both.
I appreciate that, and that's a perfectly fine answer from an education standpoint for sure. And I think just listening to your input on that, it made me self-reflect on the questions I would follow up with. Typically, was what haven't we done
Mm,
that would restore your confidence,
mhm.
right? Like, what is still that hesitation? What can we do to prove it to you that you are ready? So I think that that's a good sort of like self-reflection point for people
I
who are
ask
out
people
there.
that still all the time,
Yeah.
even when I'm the one putting together the calculated ramp up, because there are still people that are like, there's one or two things on the ACL RSI, or they literally tell me like, yeah, this one still just feels a little like I don't feel like I can kind of really go into that decel and change of direction at the same speed. Like, okay, then, let's dig into that a little bit more. Or it's like they'll rate a couple of things that are saying the same on the ACL RSI. And I'm like, can you tell me more about that? Like, what would make you closer to that 100? Because the higher the score on ACL RSI is better. So I'm still asking that all the time, because sometimes people won't, they get into the motions of it. They're invested in rehab, which is great. But then even with something like the questionnaires, they won't really address it. They won't ask themselves, to your point, like the deeper question of like, well, okay, I understand I'm not confident here, but like, why? Because we've been doing this shit for, last 2 or 3 months. What is it about it that you feel like? And sometimes it's that they haven't had contact yet. Like, okay, let's figure out a way to
Yeah. I get
do that in a controlled way first.
Yeah, I like that because I think people also have a really good sense of their bodies. And when you ask those questions, sometimes your mind, right, like this is the natural progression, you're going to get some stuff that popped up that you may not have known otherwise. But I do want to switch. It's not really completely a switch, but when you're getting into any surgery, I think mindset is a big deal. So, are there any pitfalls that you think ACLers kind of fall into that can negatively impact their care or their journey?
And you're talking still like mentally? I would say the biggest one I see the most is comparison. It's a pretty, ironically, this injury is studied so much, and yet there's still so much that we don't really know, especially with new procedures, repairs versus reconstruction, different graft types, long-term follow-up on the graft types. But, and it is common enough that a lot of times they either know somebody or have even had a different injury themselves, and it's really hard to not compare, even if all they're comparing themselves to is what the surgeon protocol says, which is tough, because I'm like glad that they have them for guidelines, and especially for maybe somebody who hasn't worked a lot with the injury. But it is very, I mean, you guys have looked at protocols. ACL isn't the only situation where you look at it and you're like, okay, they're not allowed to do knee extensions for 6 weeks, but they can squat and then they can run at 12 weeks.
Yeah.
It doesn't add up. So, yeah, that's a different conversation. But yeah, I would say that like both comparison to others, comparison to expectations that they had going into surgery, which hopefully I try to intercept and change a little bit if we can, or comparison to past self. The three of those really swirl and can cause some not great things mentally.
Yeah, I like that. And I have two examples in my mind that I've seen, especially as I was a younger physical therapist, that really kind of hit home. And they're both patients that had the same surgery on both sides of their body at different times of their life. And the first one went really, really well. So they had the exact same expectation going into the second surgery.
Yeah.
One was a meniscus and one was a bunion surgery. And both of them were drastically harder recoveries the second time around. And they were just so distraught by that concept because their expectations were completely different. And so I use those stories to try to educate people when they're going through any real types of surgeries, because it's really important for someone to know if they're trying to compare themselves to a friend or somebody else, every surgery is going to be different and your outcomes are going to be different. And it's okay if you're a little behind or a little ahead or you're right on track with some of these benchmarks. So, I use the protocols to kind of educate and say, this is somewhat what you can expect along the journey. So I think that's a really important concept to get across. So listeners, take that home with you.
It's hard. It's not like
It is
not
very
saying it's
hard.
an easy thing, but
Yeah. I
it
I'd
is.
actually like to know your thoughts on that, Steph, especially if you've seen like right and left sort of injuries, which I'm sure a lot of your athletes have had.
Mhm.
And to Joe's point, that I think that's a common thing. Like the second surgery typically is not as good as the first. Is that a pattern you found? Because I always think that kind of falls into like Louis Gifford's like vulnerable organism model. Like something changes in the state of the organism. Even though you build up resilience, maybe the capacity to handle something like that again from an ecosystem level. Is that something that you've found? Like the second one doesn't go as smoothly or lags behind it a bit?
Yes, I would say the times that it is less so or there's less of a chance of that happening is when they happen, unfortunately, like, close together,
Yeah.
because some of the reasons why I think it does happen are a little bit more to what you were talking about when you mentioned Louis. It's like enough time has passed from the first one that they forget how effing hard it is, and so they're, like, flabbergasted. If enough time has gone by, they may be slightly older. I'm not trying to be
Yeah, no,
here, but,
it's
like, it's
biology.
different.
Yeah.
It's different. I have
Yeah.
very little recollection of my initial rehab when I was 17. I just remember going to the place and letting them letting letting me choose the channel when I was doing ice and stim. Like, that's really I don't really remember. So there's those factors as well. And I think the bigger, in my opinion, again, I haven't this is not from a study, but the I have to do this again is like, so it's going to make things like finding joy in the process, getting excited and motivated, continuing to show up. It's just going to make those things so much harder. And then if you do those even slightly less, then obviously some of the physical changes are going to take a little bit longer because you don't have the same drive during it. And I can't blame anybody for that because I don't know that I would be any different if it happened to me twice.
Yeah. Completely agree with you.
So I'm really curious about just kind of talking a little bit more about what ACL rehab kind of looks like. So I want to start early stage and, what could somebody, what should they be looking for? How, you mentioned before it should be challenging. You shouldn't feel like you can go do like another workout afterwards. So how hard should it be? Can they expect? What are the goals? And I'm really curious to know how you're measuring things virtually versus what they would see in clinic and how those things kind of align.
Yeah. Yeah. So if we're going from like I'll give the base example of, isolated ACL, meaning you didn't have a meniscus surgery as well. You touched a little bit on that, but they didn't do anything to anything else besides your ACL, no MCL, no meniscus. And they used one of the usual, I will say, grafts like hamstring quad or patellar. And you don't have weight bearing restrictions. That would be the other thing. Your main job in the first really 30 days, but you can start to do more after like the first week in terms of like working out as long as you're feeling okay. That knee needs to be straight. And what I tell people is we need to define what straight means because so many times I've worked with people 3, 6+ months out who are coming to me after like an initial phase with someone, and they'll say, yeah, I have full range of motion. And then
Right.
we look at it and they can barely get to neutral on the surgery side, and the other side has like 10 to 15 degrees of hyperextension. But again, their expectation and they're told is they just need to get it straight. So we talk specifically about that and what it's going to take to get there. And usually it's, you know, don't be in your brace all the time. Take it off when you're laying down. Heel prop yourself so that there's like space underneath the knee. It needs to be able to sink into extension. Obviously, you can't do that all day. It won't feel good. We'll talk about those on off times. The other one is getting swelling down as quickly as possible. We talk about why as well. Swelling will inhibit your quads. The longer your quads are inhibited, the more muddy water we get into. So big. And so the other thing that I'll oftentimes I'm having people do early as well, because the third big one is quad activation, or maybe essentially waking them up. And I explain your brain essentially is turning the dial down on all the juice to quads on purpose. It's protective because it knows that there was just a trauma to your joint. So we're working against that a little bit. And so right now there's one left that's not crazy expensive, but like a portable stim machine that isn't like the Chattanooga or some of the bigger name ones that are probably like $300 or $400.
Right.
I understand they're investing in working with me, and I can't say, oh, you have to get all this equipment for yourself at home. So there's one that's like $60 that has enough technically milliamps or, power, if you will, to, especially in the early phases, actually be getting a pretty strong, to use NMES and get a really strong E-stim or quad contraction. So that's on their, that's the third quad contraction. They've got homework for that. And then if they are, weight bearing is tolerated. This has definitely shifted a little bit for me in the last probably 2 to 3 or maybe 5 years. I want swelling down so much more than I want them walking a bunch. So we don't have anything specific in terms of gait training in the first few days, but after that, it will likely be with at least one crutch. We're monitoring swelling, and it's not usually like taking laps. It's like, I'll call them like up and overs. Like you step up and over with being able to actually bend your knee, come back, and basically like some of the components of walking without putting a ton of weight on it, because that will kind of prolong the swelling a little bit too. So I really like to see that come down before we turn the dial up on more walking stuff, because that is another thing that's hard when it's so stiff. You can't walk normally, and then you learn to walk. There's like pretty clear research that people are distributing weight differently, and using different muscles at different times differently in the gait cycle after this injury. And some of that might even persist even if we do everything right. I'm not effing around too much with that in like the first few days to first week. It's probably a little after that. How I look at things virtually. So like I said, I mentioned before, I teach them early sweep test for swelling. So sweeping up on the inside, pushing down on the outside. If anything pushes back over, that's a positive test. Or if the swelling just stays there, like in the beginning, it's going
Right.
to. So if they are also, it's rare that they're not. So usually they also have an in-person PT, even if it's just once a week, to kind of help with some of these measurements. So I can't say that I'm doing like all of it, but I do have filmed videos, and we, can do an extra Zoom call if we need to in terms of explaining what exactly we're doing to monitor things like swelling. So they also have instructions on how to do girth measurements for knee joint line, calf, and mid thigh. But usually the in-person PTs are doing that, and I'm just getting that information from them. Oftentimes teaching them self-patellar mobs, especially if they had a patellar or a quad graft. It's definitely something that I feel like early in my career I slept on a little bit, and definitely can make a difference, especially for flexion with
Mhm.
people. So we're doing those things. And then the strength really is the first real test, if you will, because other than that, we're basically monitoring symptoms. And I'm taking a look at what their quad contraction looks like, both with the stim on, like POV with your phone, show me what it looks like, and without, because there are some indications by looking at it if there is still maybe some inhibition going on. So those are kind of like the early KPIs, if you will, not super fancy, but very just, we frequently look at those. And then I would love to, again, if they didn't have meniscus or any other issues, no hiccups, would love to get testing somewhere between, usually by weeks 10 to 12. I say that because like technically you can do it sometime between 6 and 8 weeks safely, especially if it's, you know, 60 to 90 degrees of flexion. But they're often just not tolerating like a max effort knee extension at that point. I
Right.
happen to have been doing some knee extensions and ISOs for like a good number of weeks first. And in that phase, if I'm having them test at week 6 to 8 and it flares them up, like that's not really how I want to start. And it doesn't
Sure,
happen to
sure.
everybody. Like there's those some people who just like they're like, yeah, nothing really hurts, whatever, but that's rare. So that's when we'll kind of start the more formal testing.
Is there any you mentioned how you monitor pain and you want to control the swelling, uh, and obviously the kind of swelling idea is such an objective thing that we all can look at, your clients can look at, right? And whereas pain, like especially for your athletes, I'm sure they're like, no, no, I'm okay. It doesn't hurt that bad. I can
Some of them.
tolerate a lot, right? Yeah, yeah. Some of them, yeah, some of them, you're correct. When you're progressing through this rehab, as you're kind of talking about things to kind of keep moving forward, are there ever signs, maybe like this swelling, where you're like, hey, this is a sign we're doing too much? That's a little bit more objective than, say, just a pain scale. And do you like really kind of get a little bit of leeway with swelling, or are you really strict if swelling comes back? Because I know with the sweep test, like you mentioned, there's different grades of it. So how do you approach that if you know your athlete or maybe is doing too much in their sessions?
Yeah, that's actually why that's why I filmed and like am equipping everyone with the sweep test skill because I am pretty strict with it, but I would say I am strict with swelling, but I don't freak out if it comes up. So like let's say we get it down within the first 8 weeks, which is great, but there's still a lot of people that have a little bit of lingering around that time. And again, I don't freak out as long as their quad contraction is good and they're getting like active heel pop on exactly. But yes, if it does come back, and that's part of the expectation setting too of like, once we get it down, if it comes back, even if it's just like a little bit, you just see a little pocket, it does mean that the joint is reacting in some way. It doesn't mean that I'm going to shut everything down for a week, but we are going to monitor it. I may have you do a little bit more of like elevation, like legs up on the wall midday or end of day, or, compression sleeve for whatever. Occasionally, if it's cranky enough and seems to be a little persistent, we'll try like ibuprofen for a week or something like that. I'm strict in that sense, but it also is something that, again, like there's a major surgery to the joint. Some people, this isn't their first surgery. So if when we start to get into some plyos and running, it gives us a little kickback. I'm like, yeah, I might scale back a little bit and we're definitely not going to progress until this is resolved. But it might also, the way I explain it to people too, is it may also need an adjustment period to these loads. So we're not going to increase the frequency. If anything, we might pull back a little bit, but I don't want to bring it to zero unless it's really kind of like continuing to get cranky or be persistent past like a couple weeks, because I want to allow it to, like, when we're progressing to these different phases, it's not just necessarily going to do nothing, especially after a surgery. So,
Thank you for that. And I really appreciate you mentioning the ibuprofen too, because that's the other thing I wanted to ask you about. Like working with a lot of people with these recurrent swelling things, they're just so adamant. I don't want to take anything. You know, I, I don't want to. I don't want to put this in. And I'm like, well, we have signs of inflammation or joint reaction. This can help for, like you said, 7 or 10 days, and then then we'll come off it. I promise. Like, but as long as you don't have any like liver or kidney or stomach issues, like this is 2025. We can use medicine with your rehab to help us with outcomes. So I do think I really appreciate that you said that.
yeah, have somebody doing it right now.
Okay.
So what about, let's shift here to maybe later stage. Same thing. I'm curious about like return to testing. What do you look for specifically, especially in a virtual environment? And then I'm also curious, while we're talking about that running, I've seen a lot of different things very early, much later. So when are you looking at, getting back into running, that initial process, and what kind of things are you looking for to clear them?
Yeah. With running, again, something that's probably shifted a little bit for me over the years is because I still agree it's a huge milestone, whether or not you are a runner. But if you are not a runner and it's not like the highest priority thing for you, I would rather wait. And by that, I mean, a lot of protocols will say week 12 for, uncomplicated, no concomitant procedures or surgeries done. I've found, again, unless we're talking about somebody who had like a super high level of strength and force producing capabilities prior to surgery, elite level people. Very few people are like just super ready to go at like week 10 to 12. More so from a symmetry perspective. So there's some people that actually from a like a torque to body weight ratio perspective, which we can talk about in the return to sport testing too. But in terms of how we're measuring, are they strong enough for their body weight? They might be close at around that time if they're doing really, really well. But a lot of times the other leg is just far enough ahead that something like running just looks and feels a little wonky because they're so different. And so I would rather, even if it isn't painful, so unless it's something like super high priority for them, I really like the between like 16 to 18 or even 20 week for some people because they're going to be doing conditioning. If you're doing the rehab well anyway, they're going to have been doing some form of conditioning regularly anyway. But from that, I feel like the transition for the joint tends to be a little bit better. And just the pattern itself is a little bit more natural if we can wait. But technically, if it's super important for them and or their sport and their numbers are decent, they've been doing plyos for 2 to 4 weeks, like level 1 or lower level, whatever you want to call it. They've been exposed to some sort of repetitive impact prior to running. That's one other like non-negotiable I have. If those things are feeling good at week 12, then like, sure, we can try it because the worst case scenario is like, you're not going to tear your ACL doing that. So the worst case scenario is that like they do it and they're like, they do a few rounds and they're like, this does not feel right. Or it's painful and the pain doesn't go away as they do a couple of intervals, like 30-second intervals. Then, okay, pull back for another 2 to 4 weeks and try again. In terms of the strength numbers that we want to see in this for running, I have seen so many different things. So I do think this particular one is probably like, I can give you what I would like to see, but I can also tell you that I've seen people with those numbers that it looks and feels crappy, and people who don't hit those numbers who they really want to try it and I let them and it's important to them for their sport and they do it and it looks and feels great. And I'm like, well, as long as we're monitoring swelling and it's not pissing it off, like I'm not going to tell you not to do it. We just monitor volume. So in terms of those strength numbers, ideally from a symmetry perspective, I do feel like, and like I have wiggle room with the symmetry. So if it's above 70%, meaning surgery side quad as a percentage of non-surgery side or uninjured. But I will say that I do think, again, the people that more often do well with that initiation of running are probably between 75 and 80.
Mhm.
There's some papers, research out there that will like, very hard, like has to be above 80%. I don't know, maybe it's because I've been doing it for a while and I always want to like read those things, but there's also like, if we're going back to the mental piece too, like this is all this person wants to do and this is going to be a huge win for them. And I think it might actually go okay. Like there's not anything indicating to me that it's going to be a complete disaster. And I'm going to let them try it because if it's super low volume, they're only doing it once a week. It's not pissing off the knee and they know now that they're running. I don't know. I don't know. That's maybe to your point before, Joe, that's one area I have some wiggle room on. And then in terms of torque to body weight, if it's being done isometrically and I'm looking at Newton meters per kilogram, I know that might sound weird to some people, but I would love them to be for quads as close to 2 Newton meters per kilogram. But honestly, people because there's also norms studies that they've done where people are just uninjured people are walking around at like 1.5, 1.7. So again, not that we don't create a bar for somebody, but if somebody is doing well in they're checking all the other boxes and they're at like 1.8 and their symmetry is good, we can probably try it if they want to. Does that part make sense?
Yeah, for sure. And I think the thing that you're pointing out with all the testing is the return to sports stuff that I've read is across all sports.
Yeah.
So you're recruiting people for your ACL study, but like you said, someone might just want to get back to running. Someone might need to get back to football. Someone might need to get back to hockey. And it's like, well, all of those things probably have more or less different demands. So then when you put all these people into, this umbrella, well, then this like cutoff comes up for like 80%. And, I have a meniscal transplant patient right now, and he's about 16 weeks out. He's cruising. And, we do this little torque to body weight ratio and limb symmetry thing, and he's at like 77%. And I was like, I was like, "Hey, man, you're doing awesome." I was like, "If you wanna, start running, I'm cool with it. And your swelling's minimal. You're back at CrossFit." And he's like, "Yeah, the doc just told me to wait till this time." And I was like, "All right, that's cool." But I think what I loved hearing from your story there and your perspective was the collaborative approach. Hey, yeah, I'm probably going to caution you against running if you're at 40% or if you're at point 0.3. But ultimately, the rehab process is a two-way street. Like we give information, we give guidance, and then it's up to our clients to enact that. So I really enjoyed hearing that. With all the testing and stuff, and this maybe could be from like your own data, and if you have like a big research study going and you don't want to talk about it, I'm totally cool with that. Or you
Yeah.
design something, but has there been anything that you found surprising that you just started throwing in, whether it's like a deep neck flexor endurance test? You're like, well, I haven't found any literature on this, but what I've seen is people can't control their heads or more at risk. Or is it a grip strength test, or is it something like that surprised you in these few years of like your focus in this field?
It's a good question. Maybe I should throw a wrench in there just to see. I will say that the endurance-based tests, meaning, so obviously hop tests have come under a lot of fire in the last several years, which I don't disagree with. I'll still take a look at them more qualitatively. And by hop tests, I'm talking about horizontal hop tests, like, triple hop, 6-meter hop, those types of things. But the repeated single leg hop test, so it's 30 centimeters side to side, it's single leg. And they're going for 30 seconds and they're counting how many they actually cross the 30-centimeter mark with. That's very easy to set up virtually. Whereas, like, ideally, if I had access to force plates, or somebody near them does, then um, especially for people like skiers, like single leg counter movement jump type of things, you can get better, more granular information there. But even just doing those more recently, like more consistently with people over the last couple of years versus the entire time I've been doing it virtually, is that endurance piece is definitely something I feel like earlier in my career I missed a little bit with some people, because they'll look good when we do 2 or 3 sets of 6 to 8 or something like that, like single leg, like they'll nail it, which is good. They need to be able to do that. But when we incite some fatigue, there's definitely, another subset that all of that qualitative stuff just goes, or they start to feel like symptoms or something. So that is definitely, if I were to pick one, that since doing it more often, I'll actually try to do it with people earlier on and, like, again, measure that a little bit longer, because, and even in there, the flip side of that is like, okay, for me, I only like to test things that I know are going to make me program or treat differently. Or, are they giving us information that's actually going to be like, oh, okay, this is an area where this endurance piece I'm talking about, like, I could be better at preparing them for that in the actual programming. So some of the plyos, maybe we're doing them for time instead of just doing sets and reps, especially for somebody like skier, volleyball player, things like that. I get a lot of skiers. So that was definitely something that I think was maybe not necessarily surprising, but in a way that was like, okay, yeah, this is something I need to have a little better tabs on and track.
Thank you.
I do want to be mindful of your time, Steph. So, Joe, do you have any other questions or thoughts? And I want to give you some time to talk about where our listeners can learn more from you and find you and all that fun stuff too. So,
Yeah, no, I think Steph, this is great. Thank you so much for your knowledge and sharing your perception. Um, There was one thing that we just forgot to ask, Joe, that we have to ask everybody. And as Steph was introing herself, it just seemed like a really nice segue to just kind of get into the conversation. But I do want to backtrack one thing, if it's okay with you. And Steph, we need to know, everyone needs to know, how do you take your coffee?
Oh, yes, we did forget about that. I saw them. I'm such a, like, it depends. Wow. Okay. So it's just like infiltrates my whole life, apparently. In the like right now in the morning, I'm just drinking it black, or like sometimes with just a little bit of milk. I do like, if I'm getting coffee out, um, I do like myself an oat milk latte every once in a
Very
while.
nice. Very
Not
nice.
a big sweetener thing, although sometimes I get suckered into, like, the pumpkin spice time of year. However, I
Nice.
always have to do, like, if I'm gonna do that, because sometimes it does kinda mess with my stomach, the sweeteners, but sometimes I'm like, whatever, it's worth it. But I do need to ask for like half sweet, whatever they
Yeah. Okay.
give, because then I feel like sometimes it just starts to taste chemically to me. Maybe it's just a taste bud thing. I don't know. But I am usually, we either do like drip or French press here, and it's usually like black or with a little bit of milk. I'm pretty simple.
Yeah. All right. Perfect. Well, you touched on pumpkin spice, which was actually, it was a trap question. I wanted you to go that way. You went that
Yeah.
way. So, Steph,
I
very
have
happy.
to because I'm from New Jersey too. So like it's a big, but yes, thank you guys.
Absolutely.
I do remember a short period of time where Joe was an oat milk latte kind of guy, though.
That was very brief, very brief.
It
You
was
know,
brief, but it
I
was
tried to go to
strong.
I tried to go the hipster route because oat milk was the craze. But now every time I go and order coffee, I'm like, "Hey, can I get a coffee with whole milk?" Because now there's half and half, there's whole milk, and then they're like, "Oat milk?" I'm like, "No, whole milk."
Whole and oat. Yes, that's
Yeah,
happened to
yeah,
me
yeah.
too.
Yeah, and I feel like it's like Peyton Manning and Peyton Manning. You
Yeah.
know, if you ever seen that commercial, I'm always like
Yes.
reminded of that.
Yes.
I almost want to like hold up a sign like, whole milk,
Yeah.
like with it written out.
Oat milk definitely doesn't froth as well. I'll give you
Yes,
that.
agreed.
It doesn't have the same smooth froth.
Uh-huh. Uh-huh.
All right, Steph, why don't you let our listeners know a little bit more where they can find you, and then Joy Boy can take us home.
Yes, yes. So most kind of often on Instagram, just stephAllen.dpt, or ACL Resolve. I just, to be honest, don't do as much on that one. And then clinical athlete is also, in terms of social media, that's mostly Zach and Quinn, but clinicalathlete.com and aclresolve.com have all those details. We're doing some really cool stuff with clinical athlete coming up. So we're pumped to hopefully be able to share a little bit more about that in the next few months. And yeah, pretty, open book. Anything people want to reach out about, I'm here.
All
And they should
right.
definitely
Well,
do it if they.
absolutely. Absolutely. Well, Steph, thank you so much. We love all of our guests. We love you. Joe, we love you. Listeners, we love you. Thank you so much for listening in. And don't forget to tune in next week for another episode of the Beyond Pain Podcast.